program for NCD. Uh, we welcome you to this another webinar in this national webinar series on capacity building for the state nodal officers, the district nodal officers and medical officers of the NCD program. We are joined in by the state nodal officers, the district and district nodal officers and medical officers working at PHC, CHC, and also the CHOs who are working at the health and wellness centers. And before today, our topic of discussion shall be collaborative activities between the NCD program and the TB program. Interlinkage with the TB program is one of the important components under the NCD program, and we had NP-NCD TB framework in 2018-19, and on the basis of that framework, a lot of integration has been done, although the gaps are there which need to be strengthened and covered up. But most of the states and the districts, they have been able to integrate the services, although the data recording and reporting is something which needs to be taken care of and to be regularly filled in the respective portals and the reporting formats which are shared by the NCD program. So I would like to request our expert for the day shall be Dr. Vinay Garg sir. He is an eminent public health expert in the TB program, and sir shall be taking us through the discussion on what is the importance of integrating TB and NCDs and how this integration can be implemented effectively at the field level, at the level of the health and wellness centers, PHCs, CHCs, as well as district nodal officers. What shall be the role of the district nodal officers and how the state nodal officers can monitor the implementation of the integration of the program. So with this, I would like to request Dr. Vinay Garg sir to kindly take over.
Thank you, Dr. Avinash.
Sir, over to you, sir. Welcome, sir.
Thank you, Dr. Avinash. At the outset, I would like to welcome all the participants who have joined for this very vital topic on collaborative activities for prevention and control of NCDs and TB together. So I think most of the people are very well aware about the topic and the importance of collaborative activities, as we are very well aware that it's a bidirectional occurrence and a bidirectional handling of these conditions is required. So the main conditions which we should be focusing, or we have been focusing on collaborative activities, would be diabetes mellitus, tobacco control, and most things which we can collaborate are operational in nature. Although this is only for NCDs, but there are certain other conditions also like HIV and immunocompromised hosts, which have also are at increased risk of developing tuberculosis. And we should have a bidirectional referral as well as monitoring mechanisms in place. Next. So this is the outline how we shall be going about in this session today. So we'll talk about susceptibility for tuberculosis amongst known diabetes cases, what are the frameworks, and I'll also be talking about a little bit about the 100-day intensive TB elimination campaign, the TB Mukt Bharat 100-day campaign, which we are launching tomorrow, where the main focus of the campaign is screening for tuberculosis amongst those who are not having any symptoms, like by virtue of certain conditions, non-communicable diseases, diabetes, or smokers, or alcoholism, or transplant patients, malnourishment. So these conditions make people inherently susceptible to tuberculosis, and for which we are launching the campaign. I'll be briefly touching upon that. And of course, about the collaborative activities, which all of us can undertake while we are working in the program. Next. So you are well aware that what is the prevalence and the disease load of your respective areas you are working in. Uh, TB is about 300 cases prevalence per lakh population and incidence of about, or we say nowadays not notification of about 195 cases per lakh population. So infection is 31%. We are all, most of us have a focus of infection amongst ourselves, and which can anytime get um can flare up as active tuberculosis if we have malnourishment or some stress or other conditions like diabetes, etc. So these prevalences makes it imperative for us to work together. You control of NCDs working separately, or tobacco cessation clinics working separately, and those the conditions predisposing people or their patients for tuberculosis makes it imperative that we have some bidirectional mechanisms where we can find cases of tuberculosis amongst these, and wherever we are treating tuberculosis and we find other conditions like diabetes, so we refer them for a proper care. It is important for improving the outcomes of each of us. Like if we in tuberculosis control are managing those patients who are having diabetes in a much better way, so we are reducing mortality amongst those patients, because when diabetes is managed well, the outcome of TB is better. And when the diabetes is managed well, there are less chances of the person developing tuberculosis. So these are the prevalences which make a little bit task more justified, although we are all aware of the importance of these. So next. So what conditions make metabolic conditions make people already on having diabetes more susceptible to tuberculosis? Susceptible to tuberculosis are immune dysfunctions, uh, the dysregulation of metabolism, TB-induced chronic inflammation. As such, when we all see in our clinical practice in hospitals that people who have diabetes, they have higher chances of infection, be it abscess, or they have lesser speed of wound healing, etc. So that higher level of glucose or hyperglycemia is a perfect fertile ground for breeding of pathogenic organisms. And we have also seen that the patients, tuberculosis patients which are diabetic, they have higher bacterial load. So they are 2 plus, 3 plus. Had they not been diabetic, maybe their immune system could have restricted them to 1 plus. So that hyperglycemia by itself makes the ground very fertile for infections to happen. Next. So these are clinical features, clinical things which we not very useful in day-to-day operations, but still you may go through, because this is only the immune system and CD4, CD8 T cells and some kind of altered immune response which happens within the patients having diabetes, which makes them more susceptible to tuberculosis. And when we subject such patients to anti-tubercular drugs, and two drugs, INH, rifampicin, and a little more other drugs which are hepatotoxic, makes them even more vulnerable to such dysfunctions of immune system. So their control of diabetes by itself, due to the fact that they are taking anti-tubercular drugs, becomes a little more difficult. And the possibility of other conditions like LFT getting raised, this hyperbilirubinemia, they can add to the problem of, say, discontinuation of drugs for TB, and then again, uh, the entire balance goes off track. Next. So in summary, there is strong evidence of association between glucose dysregulation and TB susceptibility. So blood sugar levels are to be monitored strictly in diabetes mellitus, and especially with people who have tuberculosis as well as diabetes mellitus. So it is essential to reduce morbidity and glycemic control. Better glycemic control is required for a good tuberculosis TB treatment outcome. So what as program managers next can do is we can plan and implement the integration at various levels of service delivery. So there is a policy level integration which can happen, like when NCD next, yeah. So we can have integration at all levels. So when each of us, like whatever programs or conditions we are dealing with, so when we are making such programs or such documents where we focus on the activities related to control of the condition which we are targeting. So when we plan at the highest level, which we have already attempted, the NCD program and their framework have included tuberculosis, and tuberculosis program in their framework have included other NCDs as well as some communicable diseases also. So while we plan, then some integrated activities in terms of IEC can always be taken up. Like there is a tobacco cessation clinic going on at a PHC or at an arm or a district hospital. We can simply have a standee displayed there that, okay, you are a smoker and you stand at a higher risk of getting tuberculosis. So it would be prudent that you get yourself tested once for presence of active tuberculosis. Same way, smokers who are coming to us and they are diagnosed. So we always can have some small booklet or small IC material where it would be ready numbers are there. This is a quit line. You can contact this person. And if those people are, while taking the drugs available nearby, so they can be counseled. A person who is taking a treatment for tuberculosis is most susceptible, or say most receptive of accepting the other advice, because that time he's suffering from a condition which he's afraid of. So at that time, if we offer that, okay, this person is going to help you quit smoking, and quitting smoking will help you get over with tuberculosis. So success of chances of success of quitting tuberculosis, smoking is higher, because that person that time wants to get a good outcome of tuberculosis. So same way, if we integrate the at the service delivery level, first is at the policy level, that we integrate our efforts, our strategies in a integrated manner. Then we deliver the services where we refer the patients to the related non-communicable disease programs, and non-communicable disease programs refer for screening to tuberculosis. And this is very much necessary, given that we have resources available for both the conditions. So when we combine, they can be jointly monitored at the local level. So district committees, comorbidity committees which have been formed, they can monthly or even more frequently at a lower level see what is the percentage of people being referred from one to other, and what is the follow-up rates. So and anything which is not monitored does not go through. So we have to ensure that at each level, say we are working at PHC, subcenter, or even district level, so we constitute mechanisms to monitor how much of integration is happening. Develop some local indicators apart from the indicators which are there in the strategic framework. These indicators, local indicators, and local responsible people could be, you make a nodal from nursing group, you make a nodal from, say, lab group, who can actually see the numbers which are being referred. So till we have the number, okay, how much from DOTS clinic they were screened for blood sugar. So that gives a quantification of our efforts. So we can now measure how much we have been successful for. Alone IEC will not help. Until any effort is matched by numbers, we cannot actually say that we have done anything. Which is not documented is not done. So this documentation will help us to plan and say improve upon our efforts whenever we say review our policies or our efforts next time. Next. So this is what I was talking about. So joint planning and review committees at national, state and district level, service delivery protocols, and after a dry run and these protocols should be developed with the people who are actually giving the services. If we are, say, sitting at an headquarter and we try to devise a pathway or an algorithm where will the patient go, how will be tested, that is more likely to be, say, more of a theoretical thing. Whatever is to be done, wherever it is to be done, a person of that level who is actually involved in the service delivery should be involved for those protocols or pathways to be successful. So joint monitoring and evaluation, both the sides bidirectionally can frame mechanisms which we have attempted in our frameworks to say document, and joint training of key program and staff would be very essential. Then they come to know of each other. Any person whom I am very familiar with, I'll be very comfortable referring my patient to that person. So joint trainings, these act as ice breaking sessions. So whenever these are there, people are able to connect with each other better. So the result of informally getting out the results, okay, I referred 3 patients of diabetes, or I referred 2 patients for smoking cessation. What has been the outcome? How are the patients and how have they been responding? So when one-to-one communication is there, so it actually benefits the outcomes. Next. This we have talked about. Next. Yes, next. Yeah, one thing which I left out is operational research. How are the things going on ground actually? Operational research gives us a very valuable insight in how execution of any activity is to be done in the most efficient manner. So operational research, I would say, would be the most important thing, and which will help us to devise real-time actual protocols which are implementable on ground. So wherever there is some difficulties going on, so we should always think of, let us put some experimental protocols, some flow charts, etc., and then test them through operational research. And whatever the outcomes and results and suggestions they come, I would request each one of you to take small operational research project, which are nothing, just testing operationally which flow chart or which algorithm and which steps function best. Operationally, what is most suitable is operational research, finding out those. So I will request each of us of who are in this capacity to undertake such things should consider taking up one project each for integration. May not be for TB diabetes. Wherever you think 2 different departments or 2 different sets of functionaries need to collaborate, you can take up such kind of research. Next. So these letters have been sent. There has been an effort at state level, national level, and district level for integration of mechanisms which monitor the activities. Next. Same way. Next. So what proportion of people or what proportion of uh, patients are getting actual service delivery from other side? Like referral, what percentage of TB patients were referred, and out of the referred, how much were actually screened for diabetes? And after diabetes, how much of them were linked to NCD clinics? Same way, uh, how much of TB patients were diagnosed for diabetes? What were their actual linkages, and how were they monitored over a period of time? So anything which is, I'll repeat for the sake of repetition also, I will repeat, anything which is not documented is not done. So we have to monitor these. We do IEC all the time. But if we do not monitor what percentage of people are actually getting tested, and after testing linkages to their respective clinics, our effort at IEC will go waste. Next. So this is the quantum of patients who were tested amongst diabetes and amongst TB for the other condition. A little bit about the 100-day campaign. So this is a campaign specifically for active case finding of tuberculosis amongst those people who are vulnerable, who do not have any symptoms as of now, but we are trying to actively find cases amongst amongst people having certain conditions, most of which are non-communicable. Next. So we are doing this campaign in 347 high focus districts. These districts have been selected on the basis of higher prevalence or higher mortality. Next. 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 So wherever you have joined from, you can see if your state is there, how many districts are there. Your state tuberculosis officers are aware of what all activities are to be carried out, what all districts are there. So if there are managers, program managers, functionaries joining from non-tuberculosis side, I would just request them to bring them to the arm centers for X-ray first and NAT upfront, even if they are not having any symptoms. And then we have circulated an algorithm by which they will decide what to do next for such conditions. Next.
I think just a minute, I want to come in. I think the state nodal officers for the NCDs, previous slide, please put on the previous slide. The state nodal officers for NCDs of the respective states who have joined. I think you can take a screenshot of this particular slide and keep it with you so that you are aware that how many districts are there for the 100 days campaign of NTP in your particular state, and actively you can coordinate with your state TB officer and the district TB officer so that the component of bidirectional screening can be done. This simply means that any patient who is coming to a NCD clinic, he reports of the symptoms of TB, then he should be sent, suppose at a district hospital if the patient is coming, so the patient should be sent to the TB clinic as well. There would be a TB clinic and of course the sputum and other examination. So that should be done at the level of the CHC. Yes, sir.
Just one more thing I would
Yes.
like to add here, Dr. Avinash. Here the campaign is about active case finding. In here, we are not waiting for symptoms to appear. As I said, by virtue of people having certain conditions, we want to screen them for tuberculosis, even if they do not have any symptoms. So any person with diabetes coming to you, or smoker, good amount of smoking he is doing, just subject them to an X-ray and decide then if sputum is there, upfront NAT. If sputum is not there, there is an algorithm we have given to each STO what to do next. But just to emphasize, without symptoms also, these patients are to be screened through active case finding and X-ray. Yes, Avinash.
Yes, sir. Yes, sir. And I think since the campaign is starting tomorrow, the state NCD and TB officers, both of them can meet today itself and discuss how to strengthen the collaboration so as to have an effective outcome of this campaign. Sir, we can move on to the next slide, sir.
Yeah, thank you, Avinash. Next, please. Yeah, these are the strategies. The purpose here is to screen 100% of vulnerable population. So although this is about NCD, we have people with HIV or malnourished people, people with past TB within 5 years, household contacts of such people. So we have to actively look for these cases. Next. Next. So this is the timeline. We have also made some indicators which your tuberculosis counterparts would be knowing of. Next. Next. So center of activity is the Niksha Shivir, what we are calling as. So there are certain handheld X-ray have been put in the mobile medical units. So what I was talking about earlier is that all such NCD patients who are vulnerable to get tuberculosis and have yet not shown any symptom of tuberculosis should be subjected to an X-ray. And these X-rays would be uh, in handheld form through the Nikshevahan, which are MMUs being used for this purpose, or state level, district level arrangement, whatever you have to take the patient to PHIs, district hospitals, CHCs, or private practitioners, whatever agreement you have. But the purpose here is each of such patient should be given an active case finding opportunity, and chest X-ray is to be done. And if sputum is there, subjected to upfront NAT. That is the two most important thing which we are trying to do this, and by which we are trying to get additional 2 lakh cases throughout the country from these 347 districts. Next. So this is the activity flow from screening to testing to notification, and then post-diagnosis workup, treatment support, nutritional support through direct benefit transfer. We now give 1,000 rupees to each patient. And if the patient is not found to be having any active tuberculosis, whether the patient is eligible for getting TPT or TB preventive treatment. Next. Community screening. Next. Yeah. So here what the first box is vulnerable population. Significant proportion of this vulnerable population is those people who are having NCDs. Next. So this is the algorithm. So now from 4S, we have expanded to 10S. So many of your patients would be also having not the classical symptoms of tuberculosis, but other non-specific symptoms like weight loss, loss of appetite, generalized fatigue, or even extrapulmonary things like swelling in neck and other organs. So these patients should be given this opportunity to get themselves screened in the campaign by X-ray and upfront NAT. Next. Differentiated TB care, the people who are having other conditions at higher risk of having an adverse outcome. So we are trying to ensure that people with diabetes or any other nephropathy or any other metabolic disorder, they get extra care for which they get a treatment for, so that the TB outcome improves. TB treatment outcome improves. Next. Roles have been defined for each of the person for this campaign. Next. This is more of a TB thing. Next. Next.
Sir, but the role of the medical officer, that particular slide, because sir, at the health and wellness center, CHO is there. At the
Mm-hmm.
PHC and CHC, that same
Hmm.
medical officer is treating the NCD on a
Both.
different day and TB
Yeah.
on a different day. So this
Yes.
particular slide will be useful, sir,
Okay.
for the HWC, PHC, and CHC.
Okay. So maybe
Yes, sir.
you can elaborate a
Ha,
little bit on this.
sir, sir, I would request, sir, if you can,
Yeah. So it is
since
more
uh,
as Dr.
what.
Avinash, it is that on different days we wear different hats, on different times we are doing different thing, although we are the same person. At district level, many a times we all know that one person is given multiple charge. He's also the nodal officer for NCD, is also nodal for immunization. So although the designations are different, the person is same. And the more we go down in the periphery, the roles integrate into one person. So if we are sensitive enough that we have to be looking for both the sides and integrate the screening and monitoring activities, it becomes easier uh, when we go down to the field level. Because eventually, our all activities converge to ASHA, CHO, ANM, and the health worker. So if they are sensitized whenever they are doing their household survey, so apart from asking from say blood sugar or any other thing, they can ask two more questions and maybe refer to the other program for screening.
The medical officer who is at the PHC, he can adequately, they can sensitize the ashas who are working there. The CHOs can sensitize the ashas to go in for the active case finding more actively during this 100 days campaign. Then when he at the CHC, when the medical officer is posted for the CHC day, he should also, they should also keep in the mind that yes, they have to screen for tuberculosis also on the there are certain days designated, I think 2 or 3 days are designated at a CHC for the NCD clinic. So they should be subjected to active case finding for the tuberculosis as well. So this way.
I would say, yeah,
Mhm.
I would say this is an opportunity that all your NCD patients subject them to X-ray. Let us for once actively see whether they have tuberculosis or not. If they do not have, at least we offer them TPT, TB preventive therapy. Yes, Avinash.
Yes, sir, that is all.
Okay, next. For any clarification, you can talk to your district tuberculosis officers. We have given sufficient funds for this program. Integration can happen without any restriction of resources. Next. Overall supervision would always lie with CMO. Next. Yeah. So this is very important that what we expect from collaborative activities. So regular meetings should happen and they should be documented. So block level report should go to district level report should go to state level, and state level report should go to national level. So, and be circulated amongst each other. So until anything is regularly done and documented, we cannot take an action. Joint capacity building, we have already talked about monitoring, bidirectional care cascade, Nikshay Shiver, joint supervision monitoring, NTP, NCD. So most of things we have already covered. Next. So probably this is the last slide. So let us take a pledge to come together and wholeheartedly try to end TB as well as we control the respective diseases or conditions we are working in. Thank you.
Sir, it was a very elaborate and comprehensive presentation, and just 3 points I would like to, just for the information of the SNOs and DNOs and MOs who have joined, that
Dr. Avinash, if you could
you
switch on
should
your
be.
camera, people can get to
I
recognize
think,
you.
sir, there is some issue with my network. I think the
Okay,
voice will
okay.
break. So if
I'll
that is
switch off my camera because then probably
sir.
you'll get some bandwidth.
Yes, yes, sir. So, all the medical officers, the CHOs, and the state nodal officers, they are requested to be the part of this 100 days campaign, the active case finding. And all the more our responsibility is more because NCDs are one of the most, the people who are suffering from NCDs are vulnerable for TB as well. So we need to be more conscious, and next 100 days, when the patients who are coming to our NCD clinics, we have to actively involve ourselves in active case finding, and of course motivate the ANM and ASHAs also who are in contact with the community for this campaign. Another thing is, since tobacco is one of the important risk factors for TB, so that component also has to be taken into account. And we have shared integrated IEC material also has been shared by with the state nodal officers for NCDs. I think that can be displayed. That should be displayed. I think at most of the centers it is being done. We during our field visits we have observed that, so that it should be kept in the mind that the TB NCD integrated IC material is also displayed at the health facility, so that will be useful for the patients attending the facility as well as the healthcare providers also. And of course, as sir has emphasized on operational research also, because operational research is something which helps us to create models which are indigenous and developed from within the community, which help us to give better models of care in terms of follow up, referral, and case finding, whether it is active or passive. And they also become a part of the best practice document. Annually, National Health Mission has a best practice document release, innovative practices they are showcased. So it is also a method for opportunity for cross learning among the different states also. So I think operational research, who all those officers who are interested in doing it, they also should actively take up that. So with this, I think we have already exceeded the time by 5 minutes. I think should we take some questions, or can we close down? Because probably.
No, sir. Sir, we have, sir, Richa this side, sir. Sir,
Yes,
we
ma'am,
have
please.
four questions.
Oh,
Uh,
oh, we
the
can take. I
first
think
Okay,
question is, sir.
we can take a few
we can
questions.
take one question. We can take one question. Let us not cross the time, because all of
Okay,
them would
sir.
be busy with some other. One test. One thing we can take is that by cross referrals, what are the
Yes.
chances of spreading TB to the other NCD individuals? What measures to prevent the spread in a busy OPD? I think, sir, would you try to answer, or
See, the
I'll
only thing
take
here
it?
is that although the patient is active, so we should ensure that airborne infection control practices are there.
Yes,
So
yes, sir.
we should not be encouraging that patient to so that give us sputum here only. It should all personal protection measures should be used to protect so as to prevent that spread of infection. So airborne infection control practices should be implemented before that person from tuberculosis is referred to the NCD screening. From NCD screening, also the person should be asked to wear a mask or visit the nearby ASHA or nearby arm, and where he can give the sample first if he has got sputum, or X-ray, whatever is required. So these practices should be ensured before a person is referred cross within the other facility.
So, right, sir. With this, we come to the end of this webinar, and we are thankful that, in spite you are already we are on a tour, and you're part of this launch campaign as well, and you took out time and shared your views on this. We are the NCD program division is thankful to you, and yes, we need to emphasize that early diagnosis, prompt treatment is important for the improved outcomes in the TB NCD patients, and one of the key methods to do it is bidirectional screening. When the patients are attending the NCD clinics, they should be screened for TB. So, in this campaign, we are doing active case finding. Of course, passive case finding also should be continuously done. Thank you. Thank you. Thank you from our side.
Thank you,
We
everyone.
can
Thank
end the
you very
meeting
much.
now. Yes.